you have augmented and mixed reality where something is projected and something's projected and interacts with the world. So that would be the definitions that I would use for now. And I bet you in about 5 to 10 years, the augmented reality technology will get really good. And at which point this definition may change again.
Thank you, Todd.
Okay.
Thank you very much. That's brilliant. May I invite Pritesh Nagar? He's a pediatric intensivist and also PediSTARS senior simulation trainer. Pritesh, what question do you have for the panel?
I have a question for Todd, and it was quite fascinating what you demonstrated just now. So I was just wondering what kind of equipment or kind of operational requirement would be there to run such a kind of VR-based simulation, especially in terms of the hardware and software.
Thanks for that question, Pritesh. This one will take a little bit, so I hope it's okay to give a long answer. And I have a lot of photos because I think it's easier to show you the hardware. And Greg, please chime in anytime, because this is also part of your purview as you've done a lot of purchases already. I think it's the next slide. Let me see. Oh, good. Okay, so there's this thing called 3 degrees of freedom or 6 degrees of freedom in virtual reality, and that's actually quite different and has very different purposes in VR. So 3 degrees of freedom, does anyone play video games in the panel? Yay, yay. I like video games too. These are video game terms for when you move, and these 3 constitute the first 3 degrees of freedom, and they're mostly rotation. If you have a phone, when you take these photos and videos, these 3 are pretty obvious to see on your phone. So if your VR allows you to do these 3 movements and you can move your head around, they're called 3DOF, 3 degrees of freedom. And so if sometimes you can just use your phone, the one in the middle that you see here is Google Cardboard. Basically, these 2 lenses, that's very, very cheap, and you can pass out everywhere. And you place your phone in there. And then so now you can actually see through the phone's camera, as well as the actual phone itself and the position, a completely new world. There are other devices where you don't need a phone, and these are, so the one on the left is the Oculus Go. The one on the right is the Lenovo Mirage, and I believe that's the Vive Focus. And because it doesn't use a phone, these devices also have a controller. So in this case, you can use a VR headset with a controller to point at things, to interact with whatever's in the virtual reality. The key thing to remember with the 3 degree of freedom is that you actually cannot stand up. Or if you start walking, the image cannot move. And you've probably experienced this when you're trying to take a panorama shot. Have you guys done that before with your phone? And what you'll see is that when you rotate their phone, it's very obvious that the image moves. But when you move your phone this way, up or down, it doesn't really make a difference on the picture. So what happens if you stand up in 3 degree of freedom is that you'll actually get really dizzy. So most 3 degree of freedom VR devices, they're very cheap, they're really convenient, but they're mostly passive. In other words, you should sit down and enjoy as you look around you. When you add 3 more movements, these are elevating, surging, and strafing, then you have a full cadre of 6 degrees of freedom, and you can finally move around in the virtual reality. Because of that, you need extra sensors and extra devices to measure where you are in space. Whereas with a 3 degree of freedom, your phone doesn't need to know your GPS location. You can stand in your bedroom, you can stand in your living room, it doesn't matter. It just needs to know which direction you're facing. Whereas with the 6 degree of freedom, you need to know what part of the room you're in or what part of the world you're in, because you can now walk around. So there are hardware devices that are more expensive, but they're really nice. This is called the outside-in 6 degrees of freedom. On the top, you'll see an Oculus Rift S. You'll see a Vive, HTC Vive Pro, PlayStation VR, and what we call the Valve Steam Index. The bottom two are really for gaming and probably not yet developed for healthcare. The top two have quite a bit of healthcare uses. And what you're seeing is that each of these, if you can see my mouse, each of these have sensors that you put somewhere in the room. I'm sorry, here are the cube sensors, and here's a bar sensor for, and then these two little cubes for the valve index are sensors. And you can put them anywhere in the room so that they can actually follow you as you move around the room. These are wired solutions, so there's always a wire that connects to a computer. Alternatively, this is the more modern Oculus Rift S, and I say modern because it came out last year, 2019. It'll probably not be modern for a few more years, but on this one, the sensors are actually inside the headset. So within this entire headset here, the sensors will keep track of the corners of the room and will know exactly where you're walking around in the room. This is still wired. This wire down here will connect to your computer, and you have these controllers that your headset will track so that they know where your hands are and what your hands are doing. And then there's now a wireless version. On the top is the Oculus Quest 2 that just got released. I don't think it's for sale yet, but it will be coming out for sale very soon. And then a couple more devices down below that are also 6 degrees of freedom and wireless and use inside-out technology. In other words, no sensors on the outside and sensors built in. And the reason you want the sensors built in is that you can actually start moving around in free space like this and have interactive simulations as well. That's more freeing. There are some devices with external sensors, and that can get really difficult to track more than 2 or 3 people. So if you need 10 people in an operating room virtually, and so far the technology is not quite there yet, but probably will be this year, you could develop a simulation with 10 people in the operating room or operating theater in VR and have them all interact with each other. Okay. So with the different hardware devices, some of it will be 3 degree of freedom passive. In other words, you cannot stand up. It's there for you to consume, just like a movie, and you can watch things as happens. There's a 3 degree of freedom active. You still have to sit down. You consume it like a movie, but you can kind of interact with the movie if you need to. And then find the full scale where you can run around. Well, okay, maybe not run, but walk around with a 6 degree of freedom active where you could truly interact with the world. And so, of course, the 6 degree of freedom active is more expensive, more fun. And then 3 degree of freedom passive is very, very cheap. The Google Cardboard, you just bring your own phone, and it's in US dollars, it's about $1. So I think that's a summary of the hardware that's required, and software is really up to you. There are software companies that specialize in healthcare simulations, and Greg can talk a little bit about that throughout the world. One of which is a company that I work with that has an office in London and Mumbai. So they have been very useful in helping with us. And then there's others like universities with the engineering departments that will make their own software as well. So programming in virtual reality is pretty similar to programming a regular video game with a few exceptions. Does that answer your question, I think?
That's brilliant. Thank you so much. Thank you, Todd. May I invite Bharat Chowdhury? He's a pediatric intensive care doctor, also one of the PediSTARS leaders. Bharat, what question do you have for the panel?
So, hi, good evening, everybody. I want to ask Todd and Greg both. So, COVID has affected us greatly, including our education system and including our innovation as well. So, how has the VR helped during the COVID blockade in simulation?
Todd, I could help field this if you'd like.
I think muted.
I don't think I'm muted. Can you guys hear me?
Yes.
Yeah, Greg, go ahead.
Yeah, good. Yeah.
So it was obviously, it changed a lot of things. If you were someone who did a lot of in situ simulation, like I did, just the idea of having new rules, of having a certain amount of people in the room made that very, very, very difficult. And the VR idea was attractive once we could see if we could figure out how to safely clean these things going from person to person, in that you didn't necessarily need to be in the same physical space with another person. Tada, if you want to add a little bit to that too.
Yeah, the VR programs allow you to do digital simulation and does not require you to be in the same space. It also allows you to recreate the environment completely. So if your learners cannot be in a hospital, but you want them to feel like they're in a hospital, the VR environment can be built so that once you're inside, and these are examples of what we've started using. It's just these clean disposable tissues. And you can actually feel like you're in a hospital, which changes the way they behave, as opposed to sitting in your bedroom, which doesn't really feel like a hospital. So yeah, so you've been able to use VR for a variety of different things when we can't use the simulation center because of COVID.
Okay, thank you.
Sorry, I always forget to unmute. Greg, this is for you, this question. You recently started VR program in your hospital. Could you tell us your journey and how you started and what you learned from it?
Sure, I'd love to. Let me see if I can share my screen here and bring a couple of slides up. Perfect. Yeah, so I wanted to take you just for a couple minutes kind of through our journey at Children's National through trying to implement VR and again, trying to bring it into the fold of the simulation that we already do in the medical education we already do. And this is specific, in my case, to a cardiac critical care unit, but would apply to any intensive care unit. And I would actually argue any, really any environment that's in the hospital, including an emergency room. So I bring this up, there's so many of these cycles, and I don't want to spend too much time on this, but sort of the idea of a development intervention. You're trying to cause a change in an organization, and you're trying to figure out how to do that. And all of these many, many models look a bit like this. And there at 12 o'clock, you have a desire to improve or change something, whether it's you have too many complications, maybe there's too many unintended extubations, maybe there's too many central line infections. There's something that you think needs to be better. Maybe you find that certain members of your staff are just not up to par and where they need to be when they're working in an environment, or you have an arrest and people seem to not do basic PALs during the arrest and you think we need to change something. So you look at the problem. This is very much of a quality improvement sort of diagram. You explore some solutions, you design some interventions, you implement them, you evaluate how they're doing, and then you begin to do the cycle again. And most of the time, we're sort of instructed to start here. What do you want to change? That's where we're supposed to be. And one of the tough things that we had at Children's National, and I think a lot of folks might run into this as if you're considering trying to implement a virtual reality program, is you might end up starting here without wanting to. And the reason is it's very attractive to a lot of your stakeholders, maybe more so than you think. And at least in our case, the funding and the interest came first, instead of the way this usually works, which is you have this awesome idea, you bring people to your side, you talk about what you want to do, and then you pitch that idea, and it takes a year or longer to get a little bit of interest and funding, and then you go from there. In our case, because this technology is so attractive, and I'm going to go into that in a moment, sometimes you end up starting here. And I'm just going to spend a few minutes talking about what happens when you start here. How do you end up going back to figuring out what it was you wanted to do in the first place? I think that this is a pretty common experience to sort of start a little bit too further around the wheel than you'd like to, too much around the wheel than you'd like. VR is new, it's eye-catching, it's futuristic. It'll attract the interest and funding from a lot of people, often before you've figured out what you want to do with it. And I'll be honest, in our case, it's a little embarrassing, but it sometimes attracts interest before you've even figured out what it is. I remember speaking with Todd, probably between a year and a half ago. And he was mentioning to me, I hear that you're going to possibly start a program there. And I said, yes, but what does the V and the R actually stand for? You know, I really was very behind in understanding what the technology was, but I was getting a lot of interest on my end from my supervisors and from our director of our hospital to get this moving in the right direction. I think it's important to go back to basics. And this is the way we design any kind of medical education initiative, or really anything when we're just trying to bring quality to the next level in our field. You have to think about who you're actually trying to reach. And we had to do a lot of work on this. Are we trying to reach just fellows in cardiology, fellows in critical care? Are we trying to reach nursing? Who are we trying to reach? And we're still answering that question. Why choose VR? And it's cool doesn't count, because it is. A lot of people are going to be really excited about it. But why are you specifically thinking about virtual reality? Why are you thinking about maybe making an investment in this? Some of the things that Todd just went through, there's a significant investment in the hardware, the software, the development, and of course, your time. Saying it's cool doesn't count. Are you trying to show that it's better than mannequin-based simulation? What advantages do you think are actually specific to the VR? What support do you have? And this is where things can get really complicated. In our specific hospital environment, I have some very talented engineers, but they're very busy and they can only be there a couple days a week. I have incredible sim techs. They're amazing. They're just learning how to set it up. And so sometimes they rely on the engineers to be able to set them up at those times. I have a vendor who's in Palo Alto, 3 hours behind us. So I have to do everything in the afternoon. Otherwise, I'm doing things at 4 o'clock in the morning, and you don't make a lot of friends that way. We're also partnering with CHLA and Todd's group, and that is fantastic. And it's been a great part of how this has been so enjoyable, but they're also 3 hours behind us and they're not physically in Palo Alto either. So that's 4 different groups in 2 different time zones, but we haven't even talked about the learners. You still have to do this for someone, right? It's not just about making a cool product, right? We're not making toys here, right? We're actually trying to invest in education and change quality. I've got ICU and cardiology fellows. They have tight schedules, limited amount of research time. And I'm basically saying to them, I can have you come at Wednesday at 2:30 and that's it. And they say, well, actually I'm on call every single Tuesday night for the next 2 months, right? And this is a common thing that we deal with all the time. And then, yeah, there's also me, right? So I have I'm a 1.0 FTE in the CICU. I work about 50 nights a year. I take 12 to 16 weeks of service a year, like probably every single person on this call. And I don't have a lot of dedicated time to this. I have to come up with my own time. So to be honest, as much as the funding is always an issue, it's really been this that's been the hardest part. And I wanted to just take you through sort of a brief timeline and then kind of turn it over to our next question. It requires patience to actually do any kind of innovation. And I think everybody here knows that. You really want to take the time to design with really concrete goals in mind, kind of going back to that 12 o'clock on that little graph that I showed you. And sometimes you have to speak with your well-meaning shareholders and push back a little and say, guys, a great product later is going to be better than a good product now, because they're going to want something right now. We've got some money, we've got some interest. Let's get this moving right now. What can you develop? What can you do in a month? This is our timeline. I know it came up a little bit small, and I'm sorry if it did. You'll see that in June 2018 is when we started some VR discussions. So fully 2 years ago. It took us a couple of months to talk with a number of different vendors to figure out who would design that. Remember, as Todd was saying, most places who have thought about doing a VR program have done this by way of a third party. And that's just because having the know-how, the technology, and the engineering to actually create this stuff is pretty difficult. And we definitely went that way. We did not have the infrastructure to actually develop this stuff. We were fortunate enough to have some funding, and then we looked elsewhere to have the actual modules developed. And by modules developed, you as a hospital-based person and an intensivist, you're writing all the logic. You're just having the actual VR developed off-site. I'm sorry, let me go back here. We started our partnership with CHLA around that time. We identified a vendor in February of 2019. And then if you look at those next 2 that I highlighted in red, from February to October, that's not a misprint. It took, getting legal folks involved and drawing up contracts. The invoice was submitted in January of this year. That took 1 entire year. The funding we had, it took us a year to actually get through the sort of legal hoops and to figure out, what to do with, who's going to own the different knowledge, who's going to own the research. And you're, again, relying on a lot of people and sometimes at different time zones, which can make things difficult too. Our hardware arrived a few months back. Our first scenario was the logic was submitted in March. Our beta versions came out a little after that, which is what I'm going to show you next. And we're bringing this to our first set of fellows this month. So for us, at least, it was a 2-year process. I don't know if it would be a 2-year process for everybody, but I think whenever you put innovation, and especially something that people don't have a lot of experience yet, into the idea of medical education, we have to really realize that we're in for the long haul and that we're just scratching the surface here. Finding space is really important, and I think we all have a different experience there. My hospital's in the middle of the city, and it's hard to find any kind of work. Like, a lot of our labs have been moved outside of the city at this point. So when you're asking for space, it's really difficult. We were really lucky to find this nice conference room, which is about 15 by 20. And the VR stuff that Todd showed you at the end there, where you have the 2 sensors in the room, most of them require a room that's about 10 by 10, 10 feet by 10 feet, or 12 feet by 12 feet. We were really lucky to get this conference room, again, just for about 3 hours every other week, but we're working on getting it even more. This is sort of the hardware setup, which we put to the side, and this is us beginning to play, moving around in the room. And again, you'll want a nice big conference room with not a lot of stuff in there. And we set up our room 30 to 60 minutes beforehand before we want to play. And that's because there's always tables, chairs, or God knows what in the room that you want to use. I was going to turn it over and try to share my screen and show you the environment here. And you'll have to just bear with me 1 second. This is going to start. So I'm going to show you a specific cardiac ICU scenario that we developed with our vendor. And this will be the first of 3 that we'll be bringing out to our fellows in the next few weeks. This is a very common post-operative issue that we see in certain patients. It's called junctional ectopic tachycardia. You're probably familiar with it. And I'm just going to orient you to a few different things. First of all, this is the moderator. This is what you would see. Yes.
Greg, you're still sharing your PowerPoint.
Oh, I'm so sorry. Thank you for.
Or your slide. You're sharing your slideshow. There you go.
You seeing it now?
Yep.
Oh, perfect. Okay, great. So this is what you would see if you were the moderator. So if you were the person participating, you'd see something much more real. This is what you see from a moderator standpoint, where you have your vital signs. This is, you have the environment, and essentially this is you getting a chance to see what your user is seeing. And then these are the different things that you can do. From a user standpoint, you'd be seeing something like this. This is an intubated post-operative cardiac baby with chest tube lines, pacer wires, ventilated, all the usual things that we see every day. You have your standard monitor here. Your drips are behind your bedside nurse, a Pyxis. There's a pacer box, which in this particular case is necessary. And you can remove the wires from the patient and put them into the box as well. And then you have things like long-term monitoring, showing what's been happening with the patient's vitals since they've come up from the operating room. I'm going to come out of this view now just to show what you would see. And you can kind of see that this patient, the vitals are not that great. The patient is tachycardic. You might notice that there are no P waves and the blood pressure is not very good. And what you can do is begin to jump to the state of this specific post-operative arrhythmia, and your users will begin to do things. Based on what they do, some of the interventions will be entirely automatic and the vitals will change accordingly. Some of the interventions, you can just jump from state to state, which is so much better in my mind than when you have a technician there who has to move the blood pressure up 10 points, move the heart rate down 10 points. Oh, wait, don't do that this time, do it this time. It's always very difficult, no matter how well you write scenarios, to make the users feel that their intervention is happening right now. If they say, we're going to give a bolus of dexmedetomidine, some Versed, and cool the patient. Let's say they try to do all those things at the same time. You'll see that the heart rate will go down quickly and the blood pressure really tanks very, very rapidly. Let's say, and I never do this with the users, but I'm going to show you. Let's say they don't do anything for a certain period of time. the patient may actually go into cardiac arrest, and of course the scenario would be ended at that time. Let's go back to the beginning, and then I'd love to have you guys participate as well. Is there anything, any of our panelists or Geeta or Todd, would you like to do anything with this patient? This is not a test. You can do anything you want. That's up here, or you can just jump to a state and kind of see what happens.
Can we give a bolus?
You want to give a bolus? Wonderful.
Adrenaline.
Oh, you want to give
mini bolus? Mini bolus.
Okay. So in this case, we're going to do that, and we can see our heart rate has gone up to 200, and transiently our blood pressure has gotten much, much better. If we wait long enough, you'll see that within about a minute, this blood pressure will continue to fall. If the participants don't do anything for about 30 minutes, if you guys can see this bar right here, the patient actually will have an arrest. Of course, I intentionally make that a really long time in the actual arrest bar because I want our participants to get a good experience. I want them to play in this environment, and I want to be patient with them. I want them to leave and come back and not feel that something bad happened. Another thing that we could do, and I'll actually come into this thing, is we could actually go up on our inotropes a little bit. This is actually now that the epi is worn off. And you can actually, if you look at your environment down here, you can actually ask your bedside provider to give some epinephrine.
Code epi given.
And you'll notice that the heart rate will continue to be high. If we wait long enough, it'll actually get even higher. You could ask him or her to start CPR.
Okay, starting CPR.
And you could, of course, ask him or her to stop CPR. And then I want to show you, I just have to come out of this real quickly and come back really quick just to show you what we would hope our interveners would do. I'm just going to show you sort of an ideal situation that they would go in. They would assess the situation. They can get a atrial EKG and ascertain that the patient, in fact, is having an arrhythmia. And they could then go and actually use the pacer box. I don't have the ability to show you guys what the use of the box looks like. It's incredibly neat. But what I can show you is, I really like how let me just go over to here. If you look at your vitals now, and now you look at your vitals when they pace, you can see what's happened with your arterial blood pressure. Your pulse pressure has moved up to 25, 30 points. And I don't have the pacer spikes on this, but you can actually see that the patient is now in a sequential A-paced, V-paced rhythm right now. It's actually, in this case, an A-paced, V-sensed rhythm. So I just kind of wanted to leave this up here for a moment. I'm sorry for the bell that you can hear. That's just part of the experience to make your users a little nervous. And just sort of take questions and see if people want to do any of these interventions. I'm happy to take them through.
Anyone?
I think the blood pressures have stabilized. The heart rate is going okay.
Yeah, this is where we would typically, in this case, end the scenario. In this case, what I did for you is we gave them a little fluid. We would want them to do the key objectives in this scenario would be initiate some sort of patient cooling, some sort of gentle sedation, fluid to support the blood pressure while you do those things, and then temporary pacing via the wires. So those are the objectives of the actual simulation. We don't expect all of the learners to do all these things. This is a simulation and they're training. And we give them about 5 minutes to do as many of these as they can. And we also record not only if they do the interventions, but the time to intervention. Like maybe some groups will give the bolus right away, but they never pace. Or maybe some groups give the bolus and cool, but it takes them the whole 5 minutes to even consider pacing, that sort of thing.
Is it okay to ask a follow-on question?
Please.
Yeah, Greg, so does this mean that, I presume that all the participants are participating virtually in this, right?
That's right, yes.
So each of them will have this software on their computer, and they will be using, at their individual sites, they will be using the Oculus Rift headset or whatever it is to participate. How does it work?
That is exactly true. I'm just going to quit the scenario for a moment just because of the noise. We can go right back if you'd like. So that is really what Todd and I are looking to do. And one of the real advantages, I think, to if you do consider doing this, to partnering with another institution, because, and Todd has been saying this all along, one of the real important things here is you could have users, as long as they're able to invest in the actual technology and the initial significant startup cost of getting the hardware, they could be playing in that environment, but the moderator, much like we're doing right now, could be halfway around the world. Similarly, you could have different users participate in the same environment, but they're not in the same physical space. One of our users could be in CHLA, one of the users could be a Children's National. Hopefully in the future, we have users at other institutions. They're in physically different places, but they're virtually in the same world. And then the moderator might be in Philadelphia, who knows, who's actually taking them through this scenario. So we think that as neat as this stuff looks, and we really think the learning will be excellent as well, we understand that that's going to take a while for people to get used to. The real advantage, or perhaps the biggest early advantage, is the ability to moderate these sessions from afar.
So that brings me to a logical follow-up question. What do you think would be the role of this? It looks amazing, and I'm sure all of us who have seen this today, it's been an eye-opener. What would you think would be the role for a developing country like India, or maybe other nations in this region, for the hospitals for this VR simulation?
Todd, would you like to field that first?
Sure. I was going to actually show some pictures of some of the things that we've done so that you can get an idea. Because there's a variety of headsets, it will depend on the purpose of what you want. So with the passive, what Greg has shown is 6 degrees of freedom active. So right now, he's on a computer. Obviously, he's not in a VR headset, and he's moderating on just the keyboard. But as a player or a learner, you are actually in there, and you should be able to walk around. So that's 6 degrees. It's a little bit expensive. You get fewer people through, but you can share the device, clean it, of course, and implement it at a school, hospital, wherever. With the 3 degree of freedom passive devices, you can actually spread an experience. For example, you can show a 360-degree video of a surgery that may be complicated. And if maybe 100 or 1,000 people take their own headsets, which for a 3 degree of freedom one, it's probably like 10,000 rupees, maybe 15,000 rupees. So it's not too bad, particularly if an institution has them. And a whole bunch of people can watch the surgery, but they can look anywhere they want. So if I want to look to the left-hand side for the surgery and you want to look on the right-hand side, we will see different things, but it's still the same live surgery or same recorded surgery. The important thing is if you're going to start this, is that any country can do this, that you still will do mannequin-based simulation here. So we have our mannequin-based simulation of a baby with seizures in the emergency department, or A&E on the right, and then the virtual version that we programmed. And we don't think that one will beat out the other, at least the way that we are intending it. So depending on how each hospital or a health ministry or perhaps a region and city wants to use VR, you get to choose whether you just want to share the experience, which is very low cost, or whether you want people to actually interact as much as, for example, the scenario that Greg had shown. So essentially, oops, sorry, where'd it go? You get, so for in this view, for example, no one is really interacting. So this is basically a passive view. So you can just watch as things are happening, and someone else is actually playing in the 6 degree of freedom and playing as the physician who's not in this scenario. So it will depend on what you want to do, whether you want to share an experience, which is really low cost and it can be widely done. And alternatively, you could also do training. I actually have better slides for that, but so as an example, here's the 360-degree surgery. So you put on the 3 degree freedom passive glasses or goggles, and you can actually see, I'll take this out for a moment. You can basically be in an operating room, move your head as naturally like you're in the operating room as much as you like. You can get picture in picture so that you're not just staring at a TV screen. You actually can look around and have situational awareness. So it's a different way of experiencing, which is passive VR. And this is really great for communities. It's very good for schools, in fact. And then you can even do rendered items like anatomy, which you'll see in the medical schools and nursing, where complex three-dimensional anatomy can be much more easily explained and interacted with virtual reality. This is Stanford Heart. So in Stanford, which is Palo Alto in California, north of us in Los Angeles, they've created this congenital heart program. So for those of you who deal with congenital heart disease, you can take the congenital heart, look at it post-operatively or pre-operatively, blow it up, and then if it's big enough, you can actually walk around inside the heart if you wanted to. And so this is what it might look like from the outside. Just blow it up, you can be a red blood cell and walk around. So there's quite a few ways of implementing it in depending on what you want to do with it. But some of it's actually quite low cost, surprisingly, particularly experiences. And the final thing that I would recommend is that if you are part of the university with engineering students, we actually have in Southern California a lot of film and cinema students because of Hollywood. And many of them actually have VR experience, or at least VR cinematic experiences. So we work with them, and the students do things for free and build us different experiences. We have a school of video games here in Los Angeles. It's a fun city. And they will be happy to build games as well. It's part of their learning process. So if you have a university, that's actually a really great place to start. And then if you're ready to go to a vendor or a company, then that's also a great place to start too.
Great, thank you so much.
Thank you, Dr. Dinkar Pai. Dinkar Pai has been with PediSTARS for a long time. He's a simulation director at MGMCRI Puducherry. So he's a pediatric surgery professor. He's been with the PediSTARS and training our trainees along with us. Thank you. May I invite Ramya Kumar. She is a physician from Manipal Academy. Ramya, what question do you have for the panel?
Hi, my question for the faculty is, what about the medical schools in the community, and how do we apply VR in India?
Again, Todd, I'll let you start. I think.
Okay, I actually have slides. So I was on Google and I actually found these pictures of some of the things that are already happening in India. So let me just show you those. Oh, hang on. So your question is about medical schools and the community within India. Is that correct?
Yeah.
Okay. So I found this. On the left is a VR for education that people are doing for school children. Again, not really for healthcare, but this is using a 3 degree of freedom with a phone and some cardboard lenses. So very, very cheap, very easy to use. And the kids are experiencing different parts of India or different parts of the world and being able to look around. It's like a virtual field trip, perfect for during COVID times. It's very low cost, and you can export experiences that are different than just looking at it on your computer. On the right-hand side is an example of mixing virtual reality with mannequin-based simulation. We call this hybrid simulation. So this person is wearing what looks like a HTC Vive Pro. So inside, he cannot see the mannequin, but the actual image that he sees is a real person. And he can touch the mannequin, and he's actually touching the person who is in cardiac arrest. There are the controllers that he's strapped to his arm, so that will detect when he's starting to do chest compressions. And this is how you can teach the community out of hospital CPR, which is really bystander CPR, which is we know is really important. Some of everyone's Gita's research as well, right? Stop the bleed and things like that. So you can teach the community different things so that instead of looking at a mannequin, they're actually in a situation where it's a real person who falls down and everyone is watching and it's very, very nervous. So you can actually train them in that. And then finally, in the medical schools, what we've seen so far is the ability of VR to do three-dimensional anatomy. So complex anatomy is really difficult to teach, particularly the brain, the heart, the parts where you have to rotate a lot. And virtual reality is really good at being able to zoom and literally look up, look down, and walk around, which actually is really much simpler to learn three-dimensional complex anatomy than if you're holding a model or looking at a book. So, and on the bottom right is, I don't know where this is from, but this is a HTC Vive. It's an old version where this gentleman is basically walking around in a human body.
Wow. Fascinating. Greg, would you like to add anything to it?
No, I think I would just second what Todd said. I again go back to the idea of collaborating with other institutions as you can, just because there is a significant startup cost here. And I think, you know, what we're just starting to see at our hospital is the ability to really, you know, harness the benefits of VR, which is once you have it developed, you can use it over and over and over again. The maintenance is so small compared to the maintenance of mannequins, which, as we all know, in 5 years, they're pretty much obsolete. They break, they need to be hooked up to a lot of other things, usually in order to run appropriately. They take up a lot of space. And as long as you can get a simple conference room, once this is developed, you can use it over and over again. So I think my thought is sort of upfront, if you can, you know, have several schools or several institutions be able to try to bring in the funding for the product. What we think is, you know, it's going to be a much better investment in medical education in the long haul.
Thank you so much. Are there any questions? Dr. Ashwini, so thank you for joining. Do you have any questions?
Yeah, I had been on YouTube earlier, and I'd like to express thanks to all the faculty for taking us this new journey. I got a brief question that we could see that how this was established in the National Medical Center in US, how they have implemented it for students. It's my, how it's being implemented for students, and what has been their experience?
Great. That's a great question. I appreciate getting it. So we've, our initial sort of target audience and participants for this has been fellows in the cardiology training area and in the PICU. And also we're moving this very quickly toward nursing in both of those areas. We haven't yet moved our efforts and our target audience to medical students or to students per se. And that's really just because of the content. It's not because that's not what we want to do. The content that we've developed is very cardiac ICU/cardiology specific. And so as a result, I think it might be a little bit much for medical students. I would say not for long though. I think medical students could get a lot out of this very quickly. I think that the idea, we're developing about 25 modules in these first 3 years. Some of those modules, though, are going to be basically PALS algorithms, you know, VFib arrest, you know, bradycardia with a pulse, that sort of thing. That stuff will be coming down the pipeline that we'll be making modules for. And that's completely applicable to nurses in training and medical students right away. So my hope is that in the near future, we are able to bring this out to a much wider group of people. We started focused basically because it's innovation, and we really wanted to make sure we had some idea what we were doing before we tried to get this out to so many people. Does that answer your question?
Yeah, thank you.
Thank you, Todd. We have a question from Levi's. Thank you, Levi's. It's a great question. Her question is, do the learners participate as a team in a single scenario?
Yes. Todd, you want to go first?
Yeah, so our program, and depends on the program, of course, and depends on what you develop. We developed ours starting in 2016, and ours is only one player. So it's physician oriented. They are what we call the code captain, or the person in charge when there's a resuscitation in an emergency. So it's single player only. We also built ours so that you could take it home with no facilitator, and they could just practice at home and let the computer guide you instead. And we did not focus on interacting with 2 or more people.
Great. Thank you. Levi's, hope that answer is okay. Sujata, are there any other questions would you like to ask from the audience?
I'm just seeing a few questions being asked. I think Shakila has asked, is there manual integration possible by learners in the virtual field, just like how they use the joystick, and whether the Oculus company is the, what can we do with it?
So I'll take that. So yes, one thing that it's difficult to show from the moderator standpoint that I showed you guys is what it actually looks like if you're wearing the headset. So our users are able to do a number of things by themselves as opposed to asking for them to be done. Those include physically going around, and I can bring up the environment again if you'd like to see this, physically going around to the back and getting medications and giving them through the central line. And then most importantly, for the specific scenario that I showed you, they can grab the pacer box, hook the wires into it, dial it to a specific number, pace the patient. And if they pace the patient at, say, 160 beats per minute, on the monitor, it shows 160 beats per minute, both on the telemetry as well as on the arterial line. So it's pretty interactive. They can also ask for the pacing to happen, and they can ask for for fluid to be given and things like that. But we've designed it intentionally both ways. They can do it themselves, which is what we certainly would expect in this very specific case where they're pacing, because that would be done by a physician, or they can ask for certain things to be done, whether that's CPR or administration of medications.
Thank you.
Thank you.
Pritesh, you seem to be having quite a few questions. Would you like to?
So, as I understand that when we are using the complete VR, what has been demonstrated, so what I felt was that would be more appropriate for someone who is an advanced learner, someone who's in zone 3, zone 4. But let's say someone who is novice, who has not really got the feel of simulation, will it affect the fidelity as well as the actual feel of, something like handling a patient, which you get by doing with a mannequin?
Very good question. So what's interesting is that Greg's version, which is really cool, is clearly aimed at somebody with good cardiac care, intensive care knowledge. I don't know how half of those things work, which is fine because that's not my training. So I would probably do quite badly in your simulation, Greg, maybe a few things. And we actually designed ours very differently for a very novice audience. So our simulation actually, for example, we have a seizure simulation, which I can't show you because I don't have a video prepared, but really only has like 4 or 5 things that the learner needs to do. Put on oxygen, look at the nurse, make sure that you communicate, place an IV, give a medication. And that's it. That's all we wanted to teach. What we wanted to do with the virtual reality was to really just get them comfortable with the beep, 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 and the scared feeling, if you will. So the scenario can be tailored to an audience. What happens is that our scenarios cannot be used for our really advanced learners, the zone 3, zone 4 learners, because it's too easy. They'll just click, 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 and you're done. And then they need to graduate to Greg's scenario, where there's a lot more options, a lot more things happening. And what we've also found is that just because VR is there does not mean that you should not do mannequin-based simulation. And so there are certain things that VR is very good at, and that is causing a small amount of stress. This is a paper that we wrote where we measured people's heart rates, and salivary cortisol levels to find out how people were reacting in virtual reality. And what we also found was that the novices react a little bit more scared than the well-trained people. So we used our VR not for training complex things, so zone 3, zone 4 items, but we used ours to basically get our novices used to and comfortable with the stress. And so we can get them to, this is a cognitive load measurement where if you're a resident and you do this, even though you do the scenario correctly, you're way more nervous than the attendings or the consultant level, the zone 3, zone 4 level. So we can tell based on your heart rate and your sweating, how comfortable you are with the simple nervous scenario. And so we can custom tailor it to the novice. And our scenario does not require you to touch the patient. So it's all cognitive skills. If you are trying to touch the patient, so psychomotor skills, surgical skills, and that's a different virtual reality scenario that other people have done. There are surgery scenarios, but it will depend. So you can design it for novices in zone 0, 1, 2, and 3.
Great. Thank you, Tori. It's been a fascinating 1 hour. I forgot that I was in Hyderabad. And is there any other questions, Sujata?
I had one question.
Are you okay to stay for a couple of minutes, Todd and Greg? Is it okay? I know it's a busy time for you. Thank you. Yeah, sure, go ahead.
My question to both Todd and Gregory. See, in our scenarios, particularly in our country, we are still at a phase where we struggle a lot with the assessments of a sick child with our residents and our fellows. So can virtual reality help us in making scenarios based on learning all these different types of assessments system-wise? So is such a scenario also possible?
Well, I think that's a great question. And I've been thinking about that a lot as well. And like I said, we sort of, in our institution, when I showed you that graph of the idea of putting the cart before the horse a little bit, the idea of getting a lot of interest, which is amazing and gets your product moving, but it sometimes happens before you've thought about who you want to reach. And a couple of months ago, we received a different grant from a very different sort of interest group in looking specifically about what you're asking, which is, in this case, it was for early recognition of like sepsis on the floor or in the ER. And it's a simple triage scenario. It's nothing at all like what I just showed you. There's no post-op cardiac care and pacers and all that fun stuff. We're designing it now actually through the same vendor. The objectives are different, but the technology is the same. And the participants in this case will be residents and nurses in training. And essentially, they will interact as a team with up to 4 people at a time with the virtual mannequin, which in this case will be a child with, tachycardia, low blood pressure, high fever, sort of some early warning signs of sepsis and evolving shock, and be expected to do basic things: establish IV access, give a little bit of fluid, speak with the supervisor, figure out if there's a PICU bed, early antibiotics, just using sort of best practices, things which we want all of our people to use, without getting too mired into the difficult logic, like what we just showed, before. And so my hope is that we can actually affect a much larger overall group of audience and reach a bigger group, precisely with what you're asking, which is, it doesn't have to be zone 3, zone 4, users in, cardiac critical care. Yes, we need to train those folks too. And we think this is going to be great for that. But I think as the product itself is becoming more popular and institutions are willing to make that financial and time investment, we can do scenarios that are just much more fundamental, if you will.
Thank you.
Bharat, would you like to ask a final question? Thank you so much, Greg, for that. Very useful. Bharat? You're muted. Okay.
So our ultimate aim is to benefit the participants. So can you share your feedback of the participants and students at your center who has participated in in-situ simulation versus VR? How they feel when they are in VR simulation versus in-situ simulation?
The feedback.
Oh, okay. Yeah, I can start. So we have different feedback depending on what device they have. We have a version that our company that we worked with made for the 3 degree of freedom passive. That's the one where you have to sit down, and as long as they're sitting still and they're calm and they're looking around like this and slowly, they feel very good. They feel very immersed in it, and you can see their heart rates racing when we project. In our scenario, we actually have a mother who cries during the resuscitation, and she's on your right-hand side. So if you turn your head and look, she will look right at you and start with this face. So we had a really great actress in Los Angeles that we modeled her face after. So we can tell when they see the mother because they do this. So we know that they're feeling these feelings. And we can also turn off the crying in the software so that the next time around, if you feel that they're novices, you just have the mother look at you like that. So because of that, we know that they are feeling the same emotions that we're trying to convey in our scenarios as the medical part is continuing. The 6 degree of freedom ones, once they get to start moving around, it feels confusingly real. In our scenario, the bed is right in front of them, and about 20% of their people will actually try to touch the bed and lean it, and there's really nothing there. So I usually have to grab them before they fall down. So they pretty much feel quite immersed. We know that for the heart rates and the salivary cortisol measurements, they experience it like so. And as long as they're not moving too fast, they won't get dizzy. It's very, especially the 6 degrees of freedom. And if you have a good computer, the graphics are very good and they feel quite immersed. And it's up to us to add the sounds, the beeping that Greg had placed, so that it feels like you're actually in the ICU.
Yeah, thank you, Todd, for that. I was in Chicago last year, and we were trying Vinay and some of us, one of the VR developed from Europe, and we were doing the CPR, and I did feel my heart rate was going up and up until I realized, no, this is just a VR and calm down. You do get immersed, and it's fascinating. Thank you for that. I think with the interest of time, we'll end that, but this is not the end, it's the beginning. I have a great news for you all, rather two great newses. Let me share my screen. Oops. Yes, so this is just the beginning. So we have more treat to come. This is kind of starter, and the main meal is going to come in October 26, 27, 28, which is going to be a virtual conference for IPSS, IPSSV. Please register, and for the low resource countries, it's free. And also on the 29th, we are going to have a research inspired meeting. Todd is one of the chair for that. So please do register and don't miss the opportunity. We're going to learn loads from that. And we also have an announcement for the country, India. PediSTARS with the Ladle. Ladle have been helping us since years. We are developing a distance simulation for the whole country, and we are going to roll it soon. We are going to announce. So I request all of you to attend the IPSSW, and then stay tuned for the announcement for the national distance simulation to come. Thank you. Let me stop. Any other final thoughts, Greg, Todd, for India? Any suggestions?
I just want to say what an honor it was for you guys to join and spend your evening with us. And thanks so much for inviting us.
I have a question for you, Greg. After the COVID, if you happen to come to India, manage to fly, where would you like to come? What would you like to see?
Well, I have 3 pretty small kids, so it's a lot of it is up to them, and what my wife and I think we can handle. We've done a few pretty big trips, and sometimes about halfway through, you're like, oh man, this one was a lot. I don't know. I've always wanted to sort of see Mumbai, but there's so much more to such a large country that I'd have to leave it to an expert.
We will be your tour guide, don't worry. Todd, the same question to you. What does India mean to you when you close your eyes? What would you like to see?
It means that there's so much innovation, so much warmth. The food is so good. I will eat too. If I come over, I will have to go to every city, you know, get the fish shrimp on the jetty and go get all the different food and from everywhere. And I will probably gain like 20,000 kilos. It'll be wonderful.
I know you won't do that. I know you. And thank you so much, Todd. Again, yeah, we are kind of, all of us here, we will be glad to take you around. We are from different parts of the country. And to a special guest, the same question, Antonio. Where would you like to go if you come to India tomorrow, post-COVID?
I already know the Golden Triangle. I would like to go to the north, to the Himalayan.
So I think we need to take Dr. Ashwini Su's help there. All right, thank you so much for participating, and to all the viewers who were there, and to your questions. We learned a lot, and we'll meet again soon at the IPS's V, not W, this year. Thank you, each one of you, the faculty and our PediSTARS leaders, for coming and helping us in this. And thank you, Step 1, for organizing such a wonderful program.
Thank you. We are really wonderful, really wonderful.
Thank you so much for the wonderful session, doctors. Watching this from a non-medical background seems so cool. I was like, oh, okay, why can't I learn this kind of a feel? And thank you all for taking time off your busy schedule and doing this for us. And dear viewers, the recorded session of this webinar will be available on our channel soon. Dr. Geetanjali, you're the best as always, and thank you for putting this together for us. Whole team of PediSTARS, you're stars as usual, so I do not have to, go ahead and say something really special because you are already stars. So stay tuned for tomorrow's session on raising awareness on first aid for children and empowering the parents and teachers by Dr. Sujata Tyagarajan here and her team. And also don't forget to follow us on Facebook, Twitter, LinkedIn, and Instagram. And for more details on Project Step 1, visit www.projectstep1.org. And doctors, don't forget to give missed call on 080-471-92219 to join the volunteer force. See you tomorrow. And thank you so much for doing this awesome session and super cool session for us. Thank you.
Thank you.
We will share the whole recorded session soon on the YouTube. There were some glitches initially. Bye-bye.
Yes, that will be shared in.
Thanks,
Thank you for coming to India.
Thank you. Have a good night.
Bye. Bye-bye.
Bye.